Hi, everybody. So would love to welcome you to our first Longevity Education Hub seminar with Dr. Aubrey de Grey, who is going to talk about the Robust Mouse Rejuvenation program and provide an update. With me today is Evelyn Biskup, Dr. Evelyn Biskup, MD, PhD. I'd like her to introduce herself as well. Dominika Volchik, who is volunteering for Longevity Education Hub. As you know, it's a fully volunteer-run initiative, so we do not get anything from this program. We really give to the community as much as possible and invest our own personal resources to advance the field. We established the Longevity Education Hub because we realized that the industry cannot move faster than the physicians. And physicians are the most important critical delivery vehicle, care delivery vehicle for the longevity biotechnology industry. So we need to ensure that physicians understand the current state of longevity biotechnology industry, the state of aging research, understand what has the potential to be effective in terms of therapeutic interventions, understand what theories have been already disproven, and start working on clinical trial designs for longevity interventions, because currently there is nothing proved, and we don't know if anything works in humans. Even people are still debating, diet, exercise, sleep, and meditation. So ultra optimization, as you know, is not going to help you escape aging. And we definitely need to have new strategies. Lots of advances coming to the research labs near you. However, we need to ensure that physicians are aware. Please make sure that you use the Q&A section to ask questions, and we'll leave the ample room for questions. And it's a great pleasure for me to have this particular webinar because we know each other with Dr. de Grey probably for around 20 years. So some of the people on this call, including Dominika, have not been born when we first met, and many people in our industry started their career, their journey based on Dr. de Grey's teachings and research. So he got his master's and PhD doctorate at Cambridge University, wrote several books. And when I started my journey in the early 2000s, well, I was always interested in aging, but 2004 I decided to switch and enrolled into a program at Johns Hopkins. There were virtually no books on aging research with the intention to actually address aging as a treatable condition. And Dr. de Grey proposed strategies for engineered negligible senescence at the time, became a very popular theory, popular framework, and we started attending his events and got into the field at scale. He started the SENS Research Foundation and donated much of his inherited wealth to the foundation, pretty much everything he had, so walks the walk. I think out of the 16 million that he got from the inheritance, 13 were donated to SRF, to SENS Research Foundation, which was pretty admirable. And he also participated in pretty much every longevity initiative out there. So now he runs the Longevity Escape Velocity Foundation, which has very similar mission as SENS, and focuses on the really practical applications now, looking at how SENS theory works in mice. And without further ado, Dr. Evelyn, maybe you want to say a few words, and let's pass it over to Dr. de Grey.
Thank you so much, Dr. Alex, and thank you so much, everybody, for joining us today. And once again, very special thank you, Dr. Aubrey de Grey, for joining us, for immediately agreeing on speaking on this very, very important topic. My name is Evelyn Bishop. I'm an MD PhD, graduated in Germany and then Harvard and Columbia. I'm an internal medicine physician and also longevity physician, co-founding vice president of the Healthy Longevity Medicine Society, and also a longevity concierge physician myself and at HLI. And right now also embedded in the new role as a medical director of the Shiba Longevity Center in Tel Aviv. It's my great honor to be here also as a co-author of Longevity Education Hub. As Dr. Alex mentioned, we really wanted to close the gap between what is known in neurosciences, in aging, in new developments in terms of longevity medicine, such as biomarkers of aging, such as biological aging clocks, and so on, and really put it into a frame that would be digestible, if I may say so, because I'm one, for MDs. Which usually need a little bit of a different curriculum since we know nothing about longevity medicine when we leave medical schools. And our hub is there not only to educate everybody for free, and it's still the only course that is CME accredited by the ACCME, which is the most credible certifying medical council at the moment. And what is very important, I think, just to mention, we have in our group today volunteers from all over the world, and we have already 7 national chapters in Indonesian, in Thai, in Japanese, in Spanish, Portuguese. We cover 80% of the global languages. And last but not least, we are entering now universities so that the new generation of medical students, residents, and doctors will already go into their clinical practice with the knowledge. But as long as we are not there yet, we really want to learn what's there on model organisms, specifically in terms of what can we do? What can we do beyond the interventions Dr. Alex mentioned that are centered around the lifestyle interventions? We are really looking forward to learning more about interventions that are pharmacologic, in terms of senolytic, steroprotectors, supplements, etc. So therefore, this topic today is extremely relevant for all of us, I hope, doctors and non-doctors. And without further ado, I'm passing the word to our dear guest presenter, Dr. de Grey.
Well, thank you very much, Eva.
Right, Aubrey, please take the floor. Thank you.
Thank you very much, Eva and Alex. It's a great honor to be the first speaker in your seminar series here, and I hope I'm going to be able to live up to that very kind introduction. I'm going to try and share my slides now. Let me see. That's there. That's good. That's even better. Okay, does that look good?
Yep, we can see you perfectly.
Yes, we can see everything.
Can see the slides.
Right. Okay, so today I'm well aware that the audience is overwhelmingly MDs, as Eva was just explaining, and I'm very much a PhD, not an MD. I have no training on the medical side. However, as Eva was emphasizing, it is absolutely critical that there should be greater bandwidth, greater linkage and communication between between researchers and medics, especially as longevity medicine emerges and becomes so much more relevant. Of course, we all expect and indeed know that in due course, longevity medicine will be the main component of medicine overall worldwide, because of course the overwhelming majority of medical expenditure worldwide is on the health problems of late life, the chronic progressive conditions that are at this point still inevitably associated with having been born a long time ago. So what I'm going to do today is go through a bit of background of the kind of approach that I've been taking over the past 20 or more years in relation to the medical control of aging, and a fair amount about where we are right now, in particular the activities of my current organization, LEV Foundation. And then once I've talked about all that, I'm going to discuss the ways in which this defines and influences the ways that MDs should be thinking now and should be preparing for the really seismic transition that longevity medicine is going to undergo over the next few years. Okay, so let's do it. First of all, I have found that my slides are not actually moving. I may have to reshare. Let me see whether that will help. Bang, share. That's it. All right. So I'm going to start by talking about this amazing person, Judy Campisi, who died just a few days ago at a tragically young age, only 74. Judy has been an absolutely monumental figure in the biology of aging for the past quarter century at least, and was a very great friend of mine. She was one of the smartest people in the field, without any doubt, and indeed, I have particular personal debt to Judy because when I first started to discuss the paradigm that I'm going to be talking to you about today, of how we might bring aging under comprehensive medical control, it was a very hard sell. It was a big shift in the thinking of the field, of the academic research field in the biology of aging. And Judy was honestly the only senior gerontologist who immediately understood what I was saying and helped to communicate it to our colleagues. So I have very fond memories of Judy, and I really believe it's a complete tragedy that we've lost her at such an early age. All right, so many of you will be familiar with, in fact, I would imagine nearly all of you will be familiar with the images I'm showing on this slide, which come from a paper that came out just over 10 years ago in Cell, and which has become, by some distance, the most highly cited paper in the whole of the biology of aging in this century. The name of the paper is, of course, The Hallmarks of Aging. And in 2013, 5 very distinguished and mainstream gerontologists declared that aging could be fairly satisfactorily described as the combination of 9 different processes depicted on the left-hand side of this slide, which could be somewhat lined up with a variety of different approaches to postponing the pathologies that arose from those processes. And this has, really become the touchstone of the field over the past decade. In fact, that is really demonstrated by the nature of these citations. Most of these citations are of the form, they're in the introduction of papers. Authors will have been working on such and such a thing, and they'll say, hello, we're working on this. You may wonder whether this is actually an important area. Well, this paper, The Hallmarks of Aging, talked about it, therefore it is. Therefore, that's all we need to say. It's become really as I say, the touchstone of the field. But it's still actually not all that widely known that this paper was essentially a restatement, in fact, not even a particularly perfect one, of another paper that came out more than a decade earlier, which was the first time in which I put forward essentially the same idea, along with, again, a number of distinguished co-authors. And I have to say, I still prefer my classification. And a large part of the reason I do is because the correspondence that you see here between the various categories on the left-hand side and the various approaches to dealing with them on the right-hand side is, well, it's a good deal tighter than it is in the Hallmarks paper, either the 2013 one or the various more comprehensive revisions of it that have come out over the past few years. Essentially, what I did in this paper, and Judy Campisi was, of course, one of the co-authors of it, was that I classified the various types of damage that accumulate during life and that constitute aging according to a philosophy that allowed me to line them up with generic damage repair approaches. And this is the key thing here, that I was focused entirely on the removal of damage, not so much on slowing down the rate at which the body creates damage. And I want to talk about that a little bit more before I go on to the kind of stuff that has happened in the meantime. Way back when I started working on aging in the 90s, it was really shocking to me how many different definitions of aging there were out there that experts in the field would propound. And these definitions were not necessarily mutually incompatible, but they definitely got in each other's way anyway, because of different emphasis, different ways of what they led people to think. Excuse me. And, this was a bit of a shame, because the divergence of ways of thinking about aging led to a great deal of confusion and failure of communication within the field, let alone beyond it. So I gravitated rather rapidly to a definition of aging which is encapsulated in the 3 words at the bottom of this slide: metabolism, damage, and pathology. I've used the word damage a couple of times already in reference to the hallmarks of aging. What is damage? Damage is simply any change that occurs to the molecular or cellular structure and composition of the body, whether it's the human body or the body of an animal, that is, number one, a consequence of normal metabolism, of the network of processes that keep us alive from one day to the next. And secondly, that accumulates over time to the point where eventually it starts to impair the ability of the body to function and starts to drive the progressive chronic pathologies of late life. That's all that I use the word damage to denote. And as you can see, that's a pretty broad, abstract definition, but that's useful as a starting point, because we must now ask, what is the goal of biomedical gerontology? What is the goal that we want to achieve by studying the biology of aging? The answer is we want to prevent the pathologies of late life. But we don't want, of course, to prevent metabolism. We want people to carry on performing metabolism, in other words, being alive. So in a nutshell, what we want to do is separate metabolism from pathology. And that is quite a useful thing to bear in mind when we consider the various options available to us to actually keep people healthy as they get older. Because this damage that's in the middle here allows us to distinguish various different generic approaches that we might take. If we think about what geriatric medicine today is, the treatment of the pathologies of late life, what we're doing is we're treating those things directly. We're attacking them directly, trying to eliminate them from the body in the same way that we might try to eliminate an infection. And you know what? It hasn't worked very well. We all know that. The question why it hasn't worked very well has not really been very well answered in the medical profession. But it's answered really rather straightforwardly and succinctly just by looking at this little diagram that I'm showing you on this slide. Because what it says is simply geriatric medicine constitutes trying to attack the consequences of something that's accumulating, namely damage. So it's kind of immediately obvious that any geriatric medicine is going to become progressively less effective as the person you're applying it to gets older and accumulates more and more damage. It's kind of obvious. Now, of course, it was already obvious a century ago to a few people. And that's why we got this field called gerontology in the early 20th century. A few people began to realize that, we're just not going to be able to address these pathologies of late life because they're not like infections at all. They are side effects of being alive. We're not going to be able to address them as if they were infections. So instead, let's try to be more preventative. Let us try to separate metabolism from pathology, not by essentially trying to separate damage from pathology, but instead by trying to separate metabolism from damage. Putting it another way, that constitutes trying to make metabolism run more cleanly and generate damage more slowly than it naturally does. And this was inspired by the living world, by the fact that we see across species a very large variation in the rate at which damage accumulates, the rate at which aging occurs. So that sounds like a really good idea. But it's got a couple of problems. The first problem it has is that if you're already in middle age and you're about to start experiencing the pathologies of late life, that means you've already accumulated a whole bunch of damage. And that damage isn't going to go away as a result of making metabolism generate subsequent damage more slowly. So really, the gerontology approach, as I'm describing it here, is only useful if it's applied starting at an early age, which is a bit of a shame because we care about people who are already in middle age or older. But the second problem with the gerontology approach is much more profound and fundamental. It is that the creation of damage is just really, really, really inextricably intertwined with the processes that metabolism needs to do to keep us alive. And disentangling them from each other is just not going to happen. They're just too intertwined. So, sure enough, we have essentially failed to postpone the accumulation of damage to a pathogenic level by the last century of research trying to do so. So the fundamental paradigm that I brought in the year 2000 and which found its full voice in the Hallmarks of Aging in 2013 is this thing I'm calling the maintenance approach. It says, well, okay, let's go back and remember that what we're trying to do is to separate metabolism from pathology. Turns out to be essentially impossible to do so by either separating metabolism from damage or separating damage from pathology. And that's a bit of a shame. But we've got another option, which is to remove damage, to eliminate damage from the body every so often. We don't even have to do it particularly thoroughly. We just have to do it every so often so that even though metabolism is generating damage at the natural rate, we have not succeeded in slowing that down. Nevertheless, the amount of damage that's in the body will not actually rise to the level that the threshold that causes pathologies to kick off. And that is a lot easier. It turns out that that's a much more straightforward approach to and practical approach to actually keeping people healthy late in life. I mentioned earlier that we can describe what the maintenance approach really is by classifying all of the various types of damage that accumulate in the body into a manageable number of categories. Here I have 7 categories, and that we can define what the maintenance approach actually is, what the damage repair is. So, for example, we can talk about replacing stem cells whose numbers just go down with age as a result of stem cells dying or differentiating so that there aren't as many stem cells as there used to be. We all know that, for example, Parkinson's disease is caused by the progressive loss of dopaminergic neurons in the substantia nigra. The reason that happens is because there are no stem cells to replace them. And right now, there are multiple clinical trials going on to fix that, to inject dopaminergic precursors which have the capacity to divide and differentiate to replace the dopaminergic neurons that the body is not replacing on its own, and thereby, of course, replenish the production of dopamine. And people are pretty happy about this. Just a few months ago, Blue Rock, one of the people doing one of these trials, announced phase 1 results, perfectly safe. Many years ago, decades ago, a Swedish group were able to show very, very strong efficacy of this approach. And that, remember, was before we knew anything really about how to manipulate stem cells in the laboratory. And for that reason, it only worked occasionally because by and large, the patients didn't get the right kind of stem cells. It was only a few patients that got lucky who did, but the ones that did get lucky got very lucky indeed and had no Parkinson's symptoms for like a decade afterwards. So this is the kind of thing that the maintenance approach can do. The various organizations that I have led over the years have been mostly working on the other things that you see here in this list, which were and certainly still are much less far advanced towards the clinic, but which are still very much going well. And the key thing I want to mention down at the bottom here of this slide is that, as at this point, we are not just talking, really early stage pre-investable work. We're actually talking about stuff that's got far enough that investors have got interested. There are multiple startups in this space. And moreover, luckily, we can also say that there are multiple approaches to actually doing maintenance. 20 years ago, when I started talking about all of this, there weren't. It was, really, I could only point to one approach for each of the 7 categories. But now, just talking about cell loss again, we of course know that we can replenish the population of stem cells of various types in the body, not only by simply injecting new stem cells, but actually also by partial reprogramming, which is a process of essentially restoring and reviving the stemness of resident cells that have become less stem-like over time. And in the interest of time today, I won't go through all of these other things, but obviously I'm happy to answer questions later. I want to give plenty of time for questions because I'm going to cover a lot of ground here. So what are we doing at LEV Foundation? Well, any kind of approach of this nature is inherently a divide and conquer approach. It's great that we've only got 7 different types or different categories of damage to address, but that's a lot more than one. So we have to develop a lot of different damage repair interventions in order to have a shot at really bringing the health problems of late life under medical control. And then we have to combine them. So those are the 2 real stages. At SENS Research Foundation, my previous foundation, our focus was to develop the individual interventions, especially for the most challenging types of damage. But at LEV Foundation, we have moved on to the next step, which is to combine interventions. The interventions we are combining are actually not the same ones that we worked on at SENS Research Foundation, because those ones aren't ready yet. They don't work individually well enough, even in mice, to be ready to be combined with each other. What we are instead doing is taking interventions that were already going pretty well in mice, 10 or 15 years ago, and have continued to progress in other people's hands, in the hands of other research groups around the world, to the point where they are ready to be combined with each other. And our criterion for starting the study I'm going to tell you about now was that each individual intervention should have shown the ability to extend both average and maximum lifespan in normal mice that were perfectly healthy and had a perfectly good average lifespan anyway, even when we started the intervention when the mice were already in middle age. So the strain of mice that we're using for this experiment is the same one that most life extension experiments in mice are done with. That's called C57 Black 6. These mice have an average lifespan in the absence of any intervention of about 31 months in most people's hands. And so we started our experiment at 19 months when the mice had 1 year left to live on average. And of course, this means that a few of them are dead already. We have had a small amount of selection, but maybe only 5%. So that doesn't really change anything. Okay, so we've got these mice. They've got a year to live. What do we do to them? Well, we chose 4 interventions that meet the criteria that I just described. First of all, there's rapamycin. Now, rapamycin will be something that's very familiar to most of you because it's been shown in the laboratory very robustly to extend mean and maximum lifespan, including when started late in life. In fact, that's how the rapamycin mania began, when a group in the US, the Interventions Testing Program, were able to show that it works pretty much as well as calorie restriction, even when you start around 19, 20 months of age. Now, you will, of course, note that rapamycin, being essentially a calorie restriction mimetic, is not really a damage repair approach. And that's true, it's not. But still, we wanted to include it because it's been so robustly validated, and because we want a good understanding of how damage retardation, calorie restriction mimetics, interact with and synergize with things that really are damage repair. All right, so what are the other 3 interventions? They all are very much damage repair. The first one is heterochromic stem cell transplant, in particular blood stem cells, hematopoietic. we have had a lot of focus in this field over the past decade on plasma exchange, on taking the plasma out of old animals and putting young plasma back. And lately, people have even been putting just phosphate buffered saline with albumin in it instead of young plasma. But there has also been work going on in parallel from other groups looking at the cellular component of the blood. And in particular, it's been shown that if you mobilize the stem cells in an older animal and therefore, vacate some of the hematopoietic stem cell niches using GCSF, then if you inject a bunch of young stem cells into those mice, of course, some of those young stem cells will occupy the niches that were vacated by the old stem cells as a result of the GCSF treatment. The result is you get a chimeric bone marrow population, some of which consists of these young stem cells. And indeed, this does extend mean and maximum lifespan. So this is one of the interventions that we are incorporating into this study. The next one is telomerase gene therapy. I'm sure all of you know a lot about telomerase. This is a somewhat complicated one for us because the telomerase biology in mice and in humans is very different. In particular, most cell types in mice already express a lot of telomerase. And indeed, their telomeres are 5 times as long as ours on average. But it turns out that their telomere maintenance mechanisms are so pathetically bad compared to humans that it still helps to give them even more telomerase. And that, again, has been shown to extend mean and maximum lifespan. And the final intervention we're using is a senolytic. I'm sure all of you know all about senolytics, drugs that selectively kill senescent cells that have got into this aberrant state. Some people call them zombie cells, where they are secreting nasty things. This was, of course, the main focus and indeed possibly the #1 most important contribution to the field of Judy Campisi, whom I mentioned at the beginning of the talk. The senolytic that we're using is called navitoclax. It's the one that has the best, most reproducible impact in the literature is in mice. And we are not using navitoclax just bare. We are actually conjugating it as a prodrug with galactose. The reason that works as a prodrug is because it turns out that senescent cells express an enzyme beta-galactosidase that breaks down galactose, and in this case activates navitoclax. And that enzyme is not expressed at significant levels in the main type of cell to which navitoclax is toxic, namely platelets. Anyway, so as I've told you, what we do is we start this therapy when these mice have about a year to live, and we're looking to see how much more life we can give them. Our goal is to double that year. In other words, to give them 1 more year so that the average lifespan starting from 19 months of age is 2 years, and the maximum is probably going to be 9 months more than that. And of course, we're measuring all manner of health span things as well. Here is the design of the study. We have not just 2 treatment groups, but 10, because in addition to the group getting all 4 of these interventions and the controlled group getting none of them, we also want to make sure that we're doing all the interventions right. So we have 4 groups, each of which is getting just 1 of the interventions. And we also want to identify antagonistic interactions, which are definitely possible. So we have 4 groups getting 3 out of the 4 interventions. And we're very careful with the controls as well. We're doing mock and naive controls. We are checking various aspects of the health of these animals as the experiment proceeds. We've innovated a little bit here. A lot of the time, in fact, historically always, what happens is that the experimenters will decide on a certain set of chronological ages at which they will do certain tests of the health of the mice and also usually sacrifice a few mice so as to obtain tissues that can be analyzed in other ways. We are doing the same thing, but we're not preordaining what ages the tests are done. Instead, we're saying that for each treatment group individually, for each separate treatment group, we wait until a certain proportion of the mice have died, and then we do the test. We believe that this will get a better signal-to-noise ratio than the traditional way of going about this. The question of what we're measuring, well, basically measuring all the traditional things that people do in experiments like this. And of course, we are benefiting from the fact that so many lifespan experiments have been done over the years And so the techniques that we're using have been very well established and refined, and we're not having to invent anything from scratch here. So we're looking at visual stuff like kyphosis and alopecia. We're looking at behavioral stuff, memory, for example, with something called the novel object recognition test. We're looking at agility. So we have something called rotor rod, strength, grip strength we look at, which works just as well in mice as it does in humans. And we're doing various blood tests, glucose tolerance, for example. And as I mentioned, we are sacrificing some tissues. Now, anyone here who fancies getting involved in these experiments, I very much encourage you to get in touch with me at the email address you see at the bottom here, because we are freezing and fixing a lot of tissues, a dozen different tissues of mice, both ones that are culled, according to the schedule I mentioned a moment ago, or that die naturally. Well, they don't really die naturally because when they get into a state where they've only got a day or so to live, they are subjected to humane euthanasia. That's the standard procedure. And we'd love to collaborate. And that quote up at the top is from the first leader of the first principal investigator of one of the most expensive experiments ever done in the biology of aging, a calorie restriction experiment on monkeys. They literally did have more collaborators than monkeys. So how's it going? Well, one of the best things about leading a group that is funded by philanthropy is that I don't have to worry about, publication priority the way academics in universities do. I also don't have to worry about, patent protection, which means that I can put out interim results whenever I like. And I've been doing so every month or two on social media. This is the most recent one. The ages at the top that you can see are not all exactly the same age, because we initiated the study split over 4 cohorts that were that were spread by 2 weeks, just in order to manage the manpower considerations at the company where we're doing this work. But of course, that all evens out in the long run. So what you're seeing here, the blue line is the control mice, and we're talking at females here. And as you can see, that group is doing less well than any other. I emphasize this is not going down to 0% on the x-axis. If you look closely, you'll see, I don't know whether my cursors are working here, that the x-axis is actually at 30% survival. So we definitely don't have they're not nearly all dead. More than 30% of them are still alive. This is females. But the red line is the group that's getting all 4 of the treatments, and as you can see, it's doing very, very much better than the control group. Furthermore, if you look at the other lines, which are the groups getting 1 treatment or 3 treatments, it all lines up really rather well as well. The dotted lines, which are here and here and here and here, are doing better than the controls, but less well than the ones that are getting 3 treatments. So it's all working out astonishingly additively. It seems like we've really got this exactly right. Now, it's a little more complicated with the males, in which you can see here that 2 of the groups that are getting 3 treatments are actually doing less well than the controls, which is again the thick blue line. But if you ignore those 2 groups for a moment, then the story is exactly the same. The group getting all 4 treatments is doing the best. I should also point out here again, this graph goes down only to 30% survival, so which means that the males here are still more than 60% alive, as opposed to something like 35% for the females. That is actually normal for this strain of mice. I know it may sound rather surprising to all of you who know that females typically live longer than males, but this strain of mice has been well documented to be an exception to that, in which males live longer. And if we look at the average lifespan with males and females combined, it's right on 50% at this point, which is exactly what we would have expected, because the experiment started just about a year ago. So everything's going well. It's not as if we don't have to worry about having short-lived controls in this experiment, which is always something that diminishes the impact of a result. So what next? Well, we definitely want to do more of these experiments. We very much want to. We know that the fact that this experiment is doing so well means that there's a huge universe of options out there. It's certain that there are going to be other combination experiments that do even better than what we're getting here. So the sooner we can bring in enough resources to be able to do subsequent experiments, the happier we will be. And we very much encourage other groups to do the same thing. There are a couple of things that we have, of strategies that we have rejected. The first is we're not going to do the same interventions at different doses. We certainly could, and there's no reason to believe that the doses we're using right now are the best. We simply tried to replicate what had been done by other groups and published, showing for each individual intervention. To some extent, we were unable to replicate that because of cost reasons especially, but we did so fairly well. And so we could change those doses. We have no idea whether those are the best doses. But we feel that that's just not going to give us as much information as we could get if we use different interventions. Another possibility, of course, is to wait and not do anything more, not go on to the second version of this experiment until we've got proper results from the first one, as opposed to these very early interim results that I showed you in the past couple of slides. But we don't believe that that's necessary either. We have a long list of very promising candidates to combine, so we think we absolutely need to go forward as soon as we can. And our current choices are here. You will have heard of some of these things, but probably not all. In particular, the first one is something that I've been very excited about for many, many years, but which has really not been picked up by the community. Turns out that you can replace the hydrogen atoms, or some of the hydrogen atoms, in organic molecules with deuterium, and as a result, alter the speed of certain chemical reactions. And if you do this with fatty acids in a particular way, then you don't change the rates of the chemical reactions that fatty acids are supposed to do, like beta oxidation, for example, but you absolutely do change the ones we don't want, which in particular are all to do with oxidative stress, lipid peroxidation chain reactions in particular. And there is now very, very good evidence, not just from animals even going into the clinic in certain congenital diseases characterized by high oxidative stress, that this is extremely powerful. So we are absolutely planning to include deuterated arachidonic acid in particular in our next study. The next one is we want to look at partial reprogramming. Of course, a lot of other people are looking at this, but they're not looking at it in combination with other interventions. Okay, SM, as I'm sure you know, are the Yamanaka factors, which were found 15 or more years ago to be able to turn back the developmental clock of cells. And large amounts of money, billions of dollars, has been put into companies exploring how to do this in vivo. Then we also want to continue the theme of introducing young stem cells into the body in order to rejuvenate it. And in this case, rather than using hematopoietic stem cells, as we are using in the current experiment, we want to use mesenchymal stem cells. I should also mention that the person who discovered those died recently, just a couple of weeks ago as well, Arnold Kaplan. So we've lost a couple of very important luminaries lately. So mesenchymal stem cells, it's now widely believed, mainly exert their beneficial effects by secreting exosomes, extracellular vesicles, and we could just be injecting those. There are some fascinating and tantalizing studies published recently that appear to show the benefits of exosomes just being injected on their own, but we believe that we may get a longer-term effect if we inject the cells that make the exosomes instead. Finally, albumin. Albumin has been shown to be a necessary component of plasma dilution. If you take plasma out of an old animal and you replace it with PBS, you have to put albumin in as well. This is no surprise because albumin is so ridiculously abundant in the plasma that the mouse just doesn't have time to make enough of it before it gets sick. So it makes sense that you would want to put it in, but we believe that the pristine, essentially younger than young nature of the albumin that's used is potentially an active ingredient. So we want to do that. And then finally, we are enhancing the baseline of this experiment. So rather than the mice just getting, the control mice just getting control chow and nothing else, we're going to give them all rapamycin. We believe that rapamycin is so well validated now that that constitutes a really sensible baseline. And finally, we're going to give them running wheels, which they don't currently have in the current experiment. This is, again, something that appears to keep mice a lot happier. So I'm going to close in the last few minutes by talking about things that really, close the circle, close the loop with you guys, the MDs. Putting me as a PhD out as the first speaker in this seminar series is a great honor. I'm extremely happy to have been here. But the reason why Alex and Eva chose to do that, I'm sure, is because they wanted to give you the right kind of background with which to be thinking about where the field is going and what you need to know in order to be ready to give your patients the benefit of new therapies as they come along. The fact is that the opportunities provided by the kinds of interventions that I've been talking to you about today are just, unprecedented, absolutely unprecedented. First of all, let's remember that we want to actually develop proper healthcare in this world, not just sick care that we have today that keeps people who are already in a bad state of health alive for longer. And damage repair has this quality of being the best of both worlds. It is preventative in the sense that we will be able to apply it to people who are not yet sick. But it's also curative in the sense that it takes people back to a younger biological age by eliminating the damage that they have been accumulating throughout their life. Secondly, we have to remember that these treatments will not just come and that will be that. They will be continuously improving as time goes on, and that will mean that progressively older people will benefit. Some of you may have heard of a concept called longevity escape velocity, which I introduced 20 odd years ago and which has now become the name of my new organization. That's basically at the point where the rate at which we can benefit progressively older people becomes faster than time is passing. But don't worry about that for the moment. Just think about the fact that these treatments will progressively improve and progressively older people will benefit. And finally, as I've mentioned already in relation to rapamycin, we have to remember that these rejuvenation therapies, these damage repair therapies, will have a very strong synergy with the longevity treatments that already exist today. I'm not just talking about rapamycin, of course. I'm talking about other CR mimetics like metformin, for example, and also weight loss drugs. Of course, we've seen the enormous impact of GLP-1 agonists in the past year or two. But there are big challenges that you guys really should be thinking about and helping to overcome starting now, not starting when these therapies land on your desk and start to be prescribable. The first thing is that, medics know that what they're doing is fundamentally black magic. You guys have to cope with the fact that there's so much that we don't know about how the human body works. And a huge part of how you guys go about that is by keeping things as simple as you can. So combination treatments are inherently challenging. And, of course, sometimes you do supply, for example, 2 different types of treatment for a cancer patient, but, you only really put your toe in the water in that regard. And as time goes on, that's not going to be how medicine is. Medicine is going to consist of combining a lot of treatments in the same person at the same time. And, getting into that mindset is going to be a big challenge. Then we, of course, have the enormous challenge of the regulatory structures that exist in this world. It's going to be a long time before the FDA and its counterparts around the world adjust to these new medicines, gene and cell therapies of the sort that I've been talking about today, as well as, of course, the idea of combining them in one treatment. So, that's a big challenge. I'm speaking to you today from a place called Prospera, which is a special economic zone in the country of Honduras on an island called Roatan. And it's currently hosting a 2-month conference called Vitalia, which is mostly focused on doing something about exactly this. The thing about special economic zones, of course, is they have a great deal of legal autonomy and are able to put regulatory structures together from scratch. And Prospera is doing it in an extraordinarily smart and well-informed way. They're not compromising at all in terms of regulatory rigor, So, you know, a lot of the, for example, the regulatory process is being led by someone who used to be number 2 at the FDA, someone who really knows what he's talking about. But at the same time, because of starting from scratch, there is so much less baggage, and so things can be put in place that massively streamline the process of going through clinical trials and identifying things that actually have real safety and efficacy. And the final challenge, which is a challenge for me as well as for you, because I do, of course, a great deal of public speaking, is that the general public worldwide are inherently resistant to preventative medicine. They understand that medicine is experimental, and they therefore have a great deal of difficulty seeing past the possibility that they will make themselves sick by submitting to medicines that are new when they are not yet sick. This is a huge, huge problem, and we have to continually educate the public to understand that preventative medicine is the way to go. At the moment, we have a few examples like statins or ACE inhibitors, but that's only because they have the most astronomical amount of prior safety data. And we cannot afford to have the world wait for as long as it took for drugs like that to become widespread as preventions. We've got to try to move faster. I will finally end by mentioning the Dublin Longevity Declaration, something that I and Brian Kennedy put together a best part of a year ago now, or six or 8 months ago. It's been signed by most of the top luminaries in the field, including, of course, Alex and Ava, and you know, it's got real credentials. It's also been signed by a very large number of people from the general public, which we definitely want to increase during 2024. And the key thing about it is, as you can see in the summary on the left, that it's a very strong statement. If you just read the text of this statement, you will be astonished, I think, at how aggressive it is in terms of saying what we have the potential to be able to do in terms of medicine for the elderly in the foreseeable future. So I'll stop there, and I hope I've left enough time for a few questions. Thank you very much.
Thank you, Aubrey, for this wonderful sharing. I'll probably start with a few questions that are on everybody's minds, and then we will progress into the general Q&A managed by Eva and Dominika. And I'll ask the first question that was on everybody's mind. Okay, rapamycin. From what we've seen from the charts that you've demonstrated currently on survival, rapamycin does seem to be doing well just by itself. And in combos, it's actually does seem to be like the strongest contributing force, contributing agent for increased survival in mice, right? And I'm not sure if you're processing the biomarkers in real time at this time, and if you're releasing this data for other people to process. But I think that rapamycin definitely found its its spot in longevity medicine, and many of the clinicians on the call are likely working on rapamycin in as part of their longevity regimen, so to speak, at least looking into including that. Can you speak a little bit about that? So in terms of the combination potential and single agent value?
Sure, yes. So you're right. At the moment, what we're seeing, especially if you combine the two sexes, is that out of the 4 individual treatment groups, rapamycin is doing slightly better than any of the other 3. And, you know, that's very heartening to us because, of course, rapamycin is out of the 4 things we're doing, the one that has been most robustly validated by other groups in the past. However, as you also say, it seems that the treatment groups that are getting combinations are doing considerably better than rapamycin on its own. So this also, again, speaks to the synergy between all of these things. We're very heartened about that. However, if we go beyond that, you know, we try to actually ask, you know, at this point, how much can we really confidently say, I honestly would want to wait another 3 or 6 months before drawing any firm conclusions. As you correctly asked the question, are we processing the health span data in real time? Honestly, we're not, or hardly any of it anyway. Especially the health span data that we will care about the most is, I think, from the tissues that we are freezing and fixing, and we're not going to even start to process them until the experiment is at least nearly over, which will be a good year and a bit from now if things go well. So yeah, I want to be a little cautious in interpreting there, but essentially I agree with everything you said.
Got it. So rapamycin seems to be the strongest agent as a single agent, right? But it has great combination potential. Why are you planning to always include rapamycin in the future studies?
Well, basically the same reason. Because it's so well validated, not only in the literature, but also in our hands, we feel that the appropriate thing to do in order to kind of maximize the amount of information that we get per dollar from the next experiment is going to be achieved by making our baseline as good as possible. It's essentially the same reason why we have chosen to put an exercise wheel in the cages every time. This is something that we honestly could have done for RMR1. The evidence was there, but we decided to just get going as quickly as we could.
Got it. And for your second iteration, for example, if a longevity physician or a company or an NGO would like to add one of their compounds or one of their therapeutic interventions to your mix, can they do it? Have you thought about that? And also, how much would it cost to just add one intervention to something like that?
So we have certainly thought about that, and we are very open to discussions on anything like that. However, at the moment, we haven't been approached by anyone for that purpose, even though I've obviously been out there publicizing the intention to do subsequent RMR experiments. So yeah, we very much encourage those conversations. Now, of course, we do want to make sure that the things that we incorporate into any of these experiments have a very respectable amount of, well, as I said a moment ago, information per dollar, so to speak, that will come out of the experiment. So we will definitely be rather picky in terms of which such things we might accept, but we will definitely take any such conversation very seriously.
Got it. So, well, you may have your first, so to speak, partner, but we're very cost sensitive when it comes to additional experimentation. So now, one final question from me. You are currently 61, right? To my knowledge.
60.
60, sorry. Bad Alex. But well, if we account for the time in the womb, probably 61 already, right? So in China, they add an additional year, by the way. So for the time spent in the womb. So my question is that so you've seen Judy Campisi pass away, right? And a few others. So it looks like we've finally see the landslide in gerontologists out there, right? So Lovnikov, Skulachov, also many others, Arnold Kaplan, right? So they just passed away. What are you doing for your personal longevity? And are you considering learning a little bit from RMR and going on to rapamycin or other reasonably safe interventions? And I don't know, maybe beer combines with rapamycin sometimes. We should probably do a combo study like that.
I always say, do as I say, not as I do, because I have been very lucky in terms of my own biological age and aging. Over the past 20 years, I've had 7 or 8 very high-end measurements of aspects of my biological age, and I always come out ridiculously young relative to my chronological age, certainly more than a decade younger than I really am. So that means that the rational approach for me is, if it ain't broke, don't fix it. Basically stick to what works and be more conservative than another person might be. However, that of course can change over time, and I'm getting tests at Human Longevity Inc. In fact, more often than I used to. I'm getting them once a year now, rather than only once every 3 or 4 years, the way I used to 10 or 20 years ago. because I definitely want to catch anything that starts to go wrong at a very early stage. However, in terms of how I see the rational approach, I think for anybody, it's really a case of the arms race, with the race between one's own biological decline and the improvement in the interventions that are available. You know, for those who have a high BMI, for example, you know, things just completely changed last year with the arrival and approval of the GLP-1 agonists. And, you know, these are the kinds of things that are constantly happening, you know, out of the blue, that we don't know how soon such and such a thing is going to improve by a step. And so, you know, just keeping one's eye on the ball and one's finger on the pulse of each of these things is vital. With regard to rapamycin per se, and indeed calorie restriction mimetics more generally, my sense is that people with a naturally low BMI, around 20, which is like me, are probably the people who will benefit the least. I've always had a very modest appetite, and I think, you know, that probably has contributed to my health over the years. I suspect that the people who find calorie restriction itself to be doable are precisely the people who will benefit the least from it. Yeah, that's just really subjective. That's just an opinion.
Got it. So now let's open the floor for questions. Let's ensure that we also read the name of the person.
Yeah. Let me run this, because I've got the chat here and I can go through some of them more quickly than others.
Oh, so, perfect.
Joe van Koningsbruggen says, why was the Swedish Parkinson trial not pursued further? Simple answer, it was too long ago. The investigators recognized that they didn't know what the hell they were doing, and that the technology for manipulating stem cells in the laboratory and selecting the right ones prior to injection was just not there. It was only when IPS came along, and of course in parallel with other huge advances in manipulation of stem cells, that people would decide the time was right to get going again. And there are now a number of groups doing this, including the group of Jun Takahashi in Japan, who was the co-author with Yamanaka, of course, on the original 2006 IPS paper. Also Jean Loring, who's been working in this field for a long time. And I should mention her study specifically because it will be an autologous study, unlike all the others. And this is the first time, it was announced at my conference last year in Dublin, that any autologous stem cell therapy has been approved for clinical trial by the FDA. So this is a huge milestone for the field in general, not just Parkinson's. Then let me just do a couple of these. Someone says, what is, Carlo Lucchesi says, what is the inter-mouse of variability within each treatment? We really can't answer that question yet. The only way we're going to be able to answer that is after we study all these frozen and fixed tissues, and indeed analyze the health span measurements that we are getting. So I don't have an answer to that question right now. Someone says, Michael Freber says, can you envision a non-invasive aging clock that's reasonably accurate? Well, they're getting better. I'm particularly excited right now about a whole new idea that was introduced by the Convoys in a paper that came out a couple of months ago, in which, rather than looking at CPG loci that change relatively linearly with age, they look at ones that do not change with age at all, but rather whose variance changes with age. And they did this initially just by doing a meta-analysis of published work, looking at the data sets that had existed and stratifying them by chronological age and seeing more variation in older ages at a given locus. But I believe that the real way to go, and I'm working with them to move forward on this, is to do single cell epigenetic analysis, which can be done, of multiple different cells from the same individual, so as to ask for the intra-individual variance and see whether that's going up. I believe it will. I believe that this will be a very powerful and systemic epigenetic clock, because it measures what I've started to call loss of epigenostasis. We all know what loss of proteostasis is. Loss of epigenostasis is something that's not been studied at all, but there's a vast amount that we don't know about how the cell succeeds in maintaining its epigenome, stopping it from changing much faster than it does. If we think about how much we do know about how the cell coped with pre-mutagenic lesions that would lead to mutations, you know, that's a complicated business. And we know nothing about how it does the same thing for epimutations. So that's huge. Let's see, what else we got? Christian Ubelia says, I got confused with the schedule. How long has the conference been going on? Yes, I think Christian is referring to Vitalia. Vitalia began on January the 7th, and it ends on March the 1st, so 8 weeks long. During those 8 weeks, there are four mini conferences, each 3 days long. The first one happened last week, and it was all about longevity. They worked me very hard. The last one will also be about longevity. That, I believe, is around February the 22nd or 23rd, but you can look this up. It's on the Vitalia website, of course. The other two will be focused on fields that are adjacent to this, especially crypto and AI, and decentralized science in general. These are areas which Prospera is, I think, really at this point already the world leader in bringing together. I believe that, I mean, the reason I've chosen to spend this entire 8 weeks here is because Prospera is the most extraordinary phenomenon as a special economic zone designed to really leverage the technology of the future, especially medical technology for the elderly. And to give the environment in which companies can move forward far more rapidly than they can in any other regulatory regime worldwide. So I deeply encourage everyone in the audience to look into this. Write to me if you want to know more. I can connect you with people who know more than me. It's an amazing phenomenon. Let me see if there's more of this. Let's see, which businesses... Yeah, so I've kind of semi-answered the next question from Zé Paulo. Which businesses could be started in developing countries such as Brazil, where the market is not so well educated and established? Honestly, I have to say, after 20-odd years of not only pioneering the research, but also doing a great deal of public interfacing, that we have to recognize that we're not going to convince the whole world of this in one go. We have to start by focusing on the people who are naturally early adopters. And so one thing that Prospera is doing is it's definitely gearing up to be the global hub of medical tourism, which is, of course, something that is designed specifically for early adopters and also for people who've got a little money. I think that's fine. I mean, the sooner it gets to everybody, the better, all of this technology that we're talking about. But that's the way it's going to do it, by a relatively small minority of people getting these treatments and being seen to have benefited far more than they can benefit from traditional treatments that are already approved in places like the USA. I think, other countries, and actually a lot of people are talking about Uruguay as an example of a country that also has very good legislation around special economic zones and legal autonomy of those zones. So it's definitely not just Prospera, but Prospera is in the lead now, I feel. Joey says, I wonder how Aubrey feels about the approach of Brian Johnson. So I know Brian Johnson pretty well at this point. And on the one hand, I think that he's benefited quite a lot from his own regime, but only because before he did any of this, he was really not looking after himself very well at all. He was rather overweight. I think if he'd already been the kind of person who, lives the way your mother told you to, then he probably wouldn't have actually seen much incremental benefit from that, starting from there. However, that's not the main thing about what Brian's doing. The main thing Brian's doing is leading by example. He's going out there and doing everything that he can, which of course is a lot more than a lot of other people can, because he's spending $2 million a year on himself. But nevertheless, he's doing everything he can to postpone his decline into cognitive and physiological ill health. And he's making it clear by the way that he is publicizing Blueprint that you don't have to spend $2 million a year. You can do, cut down versions of what he's doing. If you measure yourself a lot more than most people do, you'll be a great deal more able to look after your own health for longer. So I believe that that's a very important way to go. Let me see. I've got it. I honestly don't have anything more detailed to say about BMI. I believe that's really a question for medics, and I don't really want to try to pretend I know more than I actually do. So Alex Verdes talked about the impact of rapamycin over and above calorie restriction. And of course, this is certainly the case, that most drugs probably have multiple modes of action. I mentioned metformin earlier. Again, people are still finding new ways in which metformin actually benefits things. So yes, I think there's plenty that we definitely need to continue to discover about these drugs that have been around for a long time. And then somebody says, Benjamin McLeod says, what role will cell and gene therapies play in reducing age-related effects? They'll be absolutely central. This is really the reason why I have been focusing on those types of intervention as opposed to small molecules, for the past 20 years. I'm quite sure that there is a limit, and in fact, a limit that we have nearly reached already, to how much we can actually postpone the health problems of late life just using small molecules, and we absolutely need to broaden that and to bite the bullet of doing these high-tech things that are a lot harder, including a lot harder to get through the regulatory process, but will have so much more impact. And I think I've gone through all the questions.
In fact, you did. Thank you so much. It's so efficient as always with you. Thank you very much for picking up the questions. If you allow, I would like to also ask one question. So as we are on the topic on rapamycin, which is a very important pharmacologics for us clinicians, besides of the benefits in terms of diet or caloric restriction, we also know that there are very good benefits in terms of, let's say, cognitive performance, in terms of focus, in terms of.
Sure.
So I think that in the mice, you include the measurements that are related to behavioral neuroscience. However, I was wondering if there are also some other markers that you are planning to implement further on to get us some more insights on the benefits in that field.
We would have liked to. This was a cost thing. Obviously, the assays for cognitive performance are quite demanding in terms of manpower, and we were simply limited. So the only really straight up cognitive test that we're doing is the novel object recognition test. And that's not completely true. We are doing an open field test for exploratory behavior for some of the mice as well. So yeah, we'd love to do more. These things, the experiment, even the way we did it, it has cost $3.5 million, which is, more than most academic researchers would be able to put together. And so, and at the moment, I have to say, very sadly, that we have only so far accumulated a small fraction of what we need to do the next experiment. So anyone out there who feels like helping, we very, very, very much appreciate it.
Perhaps on that note, I've seen in many interviews have been asked that there are many attempts or wishes to start such a project in the past, but none of them really rolled out or finished or was in this dimension. And I remember you mentioned that was the main factor, the resources at large, right? Monetary and in terms of human power.
Mm-hmm. Yeah, that's right. I mean, some experiments have been done that are a little similar to ours, but much smaller. There's one going on at Albert Einstein College of Medicine that I happen to know about. Then there's a number of experiments that have been done that are similar to ours in terms of combining things, but they have restricted themselves to orally available interventions because those are so much more efficient in terms of manpower and other costs. Nobody's bitten this bullet quite the way we have.
And maybe on this note, I might ask something that we also discussed in previously a little bit in our chat or in our little conversation before, sampling. So I think Dr. Alex asked this question: what kind of samples are you storing? I think running now longevity clinic and knowing many longevity clinics colleagues, having even a mini biobank is so extremely crucial. Could you maybe comment on that?
Yeah, so totally correct. Yeah. So we recognized at the outset of this experiment that we could not know what kinds of collaborations we would be able to set up, what kinds of assays we would be able to conduct. So we hedged our bets as much as we possibly could. And the result is we've stored a dozen different tissues, everything you can imagine. Some of them we've stored in formalin, some of them we've frozen, depending on what we expect the assays to be later on. So we've kept our options as open as possible. So far, we have a couple of collaborations in the works with people who can look at epigenetic clocks, but we don't have much else yet. So yeah, we're very keen to have those conversations. But as I mentioned, probably the time when those assays will actually be performed, even ignoring financial considerations, won't be for a year or so yet, because we'll want to wait until the experiment is nearly over.
Beautiful. And with that, I would also like to pass over to our co-coordinator, Dominika, who is a Duke undergrad in behavioral neuroscience. And she had a question on the question between mortality versus life extension. So population versus experimental setting. Dominika, would you like to take over?
Yes, thank you so much, Dr. Evelyn. I hope you can hear me well. My question was that we saw the poorest survival in the mice without any intervention, but I guess they were all genetically uniform. But taking it from the behavioral neuroscience standpoint, do you see that, for example, in the novel object recognition tests or in the Rotarod tests, did the mice with all treatments actually perform better than in case of health span and the let's say quality of life, if you can call the mice like this?
Yeah, so we haven't done any detailed quantitative analysis of this yet. By and large, at the moment, the data that have come in have been actually quite preliminary. So I showed you a graph in which we have these particular points at which we do these analyses. Some of the groups have only reached the first of those points so far, when only 20% of the mice are dead. And of course, we would expect at that point that there will be very little decline in performance of whether cognitive or physiological relative to the baseline, where of course we measured everyone before we started. Call point 2, as we call it, will be the one where we can really start to ask that question a bit more usefully, and that's when roughly 50% of the mice are dead. And we would expect that so some of the groups have already reached that point, but the treatment groups that are getting all 4 treatments have not reached that point yet. So we might be able to answer that question in a couple of months from now.
Wonderful, thank you. And if I may allow myself to ask one more little question, a note on the translational science here. To what extent does it give us the hope as humans, the study in robust mice rejuvenation?
Yeah, I mean, of course, this is the question that relates to essentially all mouse work in any medical area, is how translatable is it? And one thing that we're very cognizant of is that we should be trying to identify the ways in which the differences in mouse biology and human biology can be, if you like, cancelled out by changes to the treatment in terms of how one would design the human version of what we're doing. So, for example, I mentioned how different the biology of telomeres is in mice versus humans. That may lead to differences in how we would want to go about using telomerase or other telomere manipulations. One thing I'm particularly keen on right now is a treatment that announced spectacular preliminary results at my conference last year in Dublin, a company named Maya Biotechnology that's looking at a way to eliminate all telomerase positive cancers using a small molecule that disrupts the telomere, but only in telomerase positive cells. And so, of course, that's very orthogonal to the telomerase supplementation that we're doing in mice right now. These are the kinds of considerations that we will need. But of course, figuring out what works in mice in the first place is the first step. You can't start without that.
Fascinating. Thank you so much, Professor.
All right. So with that, let's conclude our session for today. Thank Dr. de Grey with a round of applause. And we all hope to see him in Copenhagen in August to September, presenting his wonderful results on RMR. Hopefully at that time it will be close to completion, and we'll be able to see some very strong signals. So thank you very much, and a round of applause. We had over 100 participants joining from the physicians community, and actually much larger during the peak. And if you have any more questions, please address them with Dr. de Grey directly. Thanks so much. And Aubrey, please do enjoy Vitalia.
Absolutely. Thank you so much for having me again. It's been a great privilege, a pleasure. Bye for now.
Thank you. Bye-bye.
Thank you so much. And dear participants, please watch out for the newsletter that is going to be the summary of this webinar. Thank you, and have a good day or night or whatever in time zone you might be right now. Thank you
so much. We also see that there are some more questions coming. Please feel free to email us at Longevity Education Hub, and we will pass the questions to Dr. de Grey. But you can also find him on social media, and he's very responsive. And please also send us suggestions of who you would like to hear next in the next coming months, years, so that we can hopefully facilitate and respond to your interest. Thank you so much.
Thank you, everybody. Goodbye.